Thank you, Dr. Chang. And hello to all our listeners for the Hot Seat podcast. I'm going to be the moderator. My name is Jens Berli. I am an associate professor at Oregon Health and Science University in Portland, Oregon, with focus on gender surgery. In that role, I'm also a fellowship director for our gender surgery fellowship. And I had this opportunity as the ASDS EdNet host today to decide on a topic that would fit within the section of microsurgery and reconstruction. And so, of course, naturally, phalloplasty is something that's near and dear to my heart. So I figured we'll take a dive into this topic and get surgeons together that may not agree 100% on what is the ideal phalloplasty or what they offer for complex patients. And so I'm very excited to be joined today by two of my colleagues. First off, we have Dr. Rachel Bluebond-Langner. She's an associate professor at NYU Langone. And then Professor Marlon Buncamper from the University of Ghent in Belgium. And I'm very excited to have this transatlantic exchange because healthcare settings differ, and that may also influence the flap choices and so on. But before we dive into the conversation with the guests, I wanted to give a bit of background to listeners who may not be as familiar with phalloplasty, and in a very brief kind of summary, discuss how we achieve the goals of phalloplasty, which is sensation, aesthetics, dimensions, possibility for an erectile device, and then also the ability to urinate. And also we will touch upon alternative phalloplasties, such as the shaft only. Now, when you decide what type of phalloplasty you're going to offer, there's essentially three things you have to think about. Where do you take the tissue from? What type of design are you doing? Meaning, is it a tube within a tube? Is it a shaft only design, like a trapezoid? Or is it a composite flap, so using two separate donor sites, one for the urethra, one for the shaft? Or do you use graft material in order to create the urethra? And if you do so, are you going to pre-laminate or are you going to use the graft material at subsequent surgeries? And then when you've made those decisions, the question is, do you do most of that in one stage and then erectile devices later? Or do you create the shaft and the neo-urethra in the shaft first and connect the native urethra to that shaft urethra at a second stage, creating the scrotum, burial of the clitoral tissue, and so forth. At the second stage, this would be the Big Ben method. Or do you create a metoidioplasty first, so you're doing all the urologic surgeries first, creating of the scrotum, and so on, and create a mini phallus from which the patient's urinating, and then come back later and create the shaft and shaft urethra. Or again, with the grafted versions, there's a variety of stagings. So I hope that gives you a little bit of a background around what we're talking about. And then also think about the complications in phalloplasty as flap-related versus more urologic complications. So without further ado, I want to welcome our guests and we will start our conversations.
I'm very excited today to have Professor Marlon Buncamper from the University of Ghent, as well as Dr. Rachel Bluebond-Langner from NYU on this podcast. So one of the first things that I would like to hear from the two of you is just a brief overview over your practice in terms of phalloplasty or masculinizing genital gender-affirming surgery, and maybe also tell us in a word or two a little bit about the healthcare setting that you're practicing in. And maybe we'll start with you, Rachel.
Thanks so much, Jens, for inviting us. I'm looking forward to a good discussion. So I am in an academic setting at a university, and I work as part of a multidisciplinary team. So we offer phalloplasty as a combined procedure between plastics and urology. We accept insurance, Medicare, Medicaid, as well as commercial plans, and feel that this is individuals' right and it's medically necessary surgery, and have been fortunately able to get it covered in New York through Medicaid.
How about you, Marlon? What kind of healthcare setting, the University of Ghent? I assume it's a single payer. Do you have all your patients coming through the public system, patients from out of state, meaning from out of country in Europe? And tell me a little bit about your phalloplasty practice in more detail.
Yeah, thank you, Jens, and thank you for inviting me. At least then maybe we can have a little view of how it goes in Europe. So we're the university hospital also. It is the only center in the whole of Belgium that does the phalloplasties. So we get the phalloplasty of the whole of Belgium and even the north of France. So in Lille, which is about an hour and a half away from Ghent, even though it's another country. So we do quite a bit of phalloplasties. At least once a week we do a phalloplasty. and together with a urologist. We would be able to do more, but due to the scheduling, it's not very possible to do more than one a week. Furthermore, the patients usually have it all reimbursed by the insurance companies. So we have a national insurance company, and that reimburses the patients. The patients do have to pay a fee, but it's very little. And we do accept people from the north of France and anywhere else, but they do have to be seen by our psychologist beforehand. So that's something that we made an agreement with the psychologist that everybody that is operated in Ghent has to be seen by one of our psychologists. And there is where we get the bottleneck. And that's why we don't have that many patients anymore from outside of Belgium. We do still have them. And especially if it's a secondary cases, we do get patients from all over Europe. So, and we also do all the DSDs, so diseases of sexual development. So because of that, we also do phalloplasties for cis biological men.
Thank you, Marlon. So that kind of brings me over to the next question in terms of how do we evaluate patients? And I don't want to focus too much on the kind of standards of care and kind of assuming, the psychosocial and those aspects are kind of taken care of. But more specifically in this talk, I want to drill down more into the technical aspects. How do you evaluate a patient in your practice when they present for a phalloplasty? And also what type of surgeries do you offer?
All of our patients have to go to what we call an information info session, which is a session in which we give all information, all the types of phalloplasties that are done. So that's a requirement. Once they've been to that, then they can decide what type of phalloplasties best suit them. And then when they come to my office, then I can see if their morphology is good enough for the type of operation they want. And of course, we'll see if there's a medical reason why we wouldn't do certain operations, if there's a psychological reason why we wouldn't do certain operations. And then we discuss that with a patient. And so we come to the decision what we can do. So we do most types of phalloplasty, so from ALTs, skips, free radial forearm flaps, of course, with or without urethras. We do that also. And when I used to work in Amsterdam, we also used to do with remnants of the vagina, so we would leave the vagina intact. In Ghent,
we'll get into some of those kind of controversial.
That's what I'm saying. So yeah,
in a second. And so, if I'm hearing you right, your patients go through a educational session and essentially get offered pretty much all variations of phalloplasty that are out there, or are there some that you would not offer?
The only one I haven't offered yet is the abdominal one. The abdominal phalloplasty. That's the only one we haven't offered. We used to offer the fibular phalloplasty, but due to our experience with it, we don't do that anymore either. So everything else is nearly a go. I know that certain places they do LD, latissimus dorsi flap. Never did that one. So I think that's all of them, but the most common ones we do.
All right, we'll get more into depth on all that. Rachel, what is your approach for patients that come and want the services at NYU?
So we start out with a discussion about what their goals are for phalloplasty. So everybody's goal for phalloplasty isn't going to be the same. We ask questions about the ability to stand. We ask patients to prioritize ability to stand, to urinate, erogenous sensation, ability to have penetrative intercourse, and then what the individual is thinking in terms of appearance. So length, girth. And based on this helps us guide what components we offer as part of the phalloplasty. So not everyone will have urethral lengthening, not everyone will have vaginectomy, not everyone will have scrotoplasty, not everyone will have an erectile device. Also, based on what they report as their goals, we try to match the donor site. So for example, if sensation is more important, we may steer them towards a radial forearm. Or if they have a thicker thigh and are concerned about a very thick or a penis with a lot of girth, we'll steer them away from the anterior lateral thigh. In our hands, we offer two donor sites. One is the radial forearm and the other is the anterior lateral thigh. In selected patients, we have done and do offer the abdominal phalloplasty. But again, we have to make sure that the goals of the patient match up with the donor site. So in our hands, we find that the abdominal phalloplasty is a bit more limited in terms of sensation and the ability to stand to urinate. I used to do the latissimus dorsi. I no longer offer that as a donor site. And I've never offered the fibula.
I mean, I think it's interesting. I don't know what all of yours experience has been seeing phalloplasties that have been performed in the 90s. So we have a few patients that come through, and it's not a new field for listeners on here who may not know much about phalloplasty or are starting into the field. Sometimes we feel this is a new procedure, and Marlon, you can attest to that. I've been around the block for a long time with Amsterdam again, kind of leading the charge in Europe within these surgeries. So a lot of different forms have been tested and tried. And so the focus for a big part of this discussion for me is to drill a bit deeper down into what are the things that you believe in, what are the things that you feel you get good outcomes in, consistent outcomes. And that may be different from surgeon to surgeon. And then so that's kind of where we want to kind of go from here. So to go more kind of systematically, let's talk about complete phalloplasty or classic phalloplasty, which essentially would mean all the components that I mentioned in my introduction, with the main component being the urethral lengthening. And so, Rachel, you talked about donor sites that you are using or offering, and what type of flap design, and what type of staging, and do you use graft material for the urethra, or do you use a vascularized urethra? What's your favorite approach to that?
So we offer a stage approach for both. Again, the two donor sites that we use are radial forearm and anterior lateral thigh. For both, we offer a staged approach to urethral reconstruction. For the radial forearm, we do a tube and a tube. So the pendulous portion of the urethra is vascularized, and then use local flaps, the labia minora, and part of the vaginal mucosa for the proximal urethra. We create the shaft first and then complete the urethral reconstruction in a second stage, generally 3 months, sometimes a little bit longer later. For the anterior lateral thigh, we again begin with the reconstruction of the shaft, and you perform the proximal portion of the urethra in a similar fashion to the radial forearm. So the vaginectomy, using the labia minora to tubularize the proximal urethra. But there are two stages for the pendulous portion. After we open the anterior lateral thigh flap again, and we lay in a thick split thickness skin graft, we allow this to heal. And again, at 3 months, we come back and tubularize that again. So for the anterior lateral thigh, there are essentially 3 stages, whereas for the radial forearm, there are 2 stages for urethral reconstruction. We also never combine placement of erectile device or testicular implants with the urethral reconstruction. We separate those. We scope the patient, make sure that there are no urethral issues prior to placing any kind of foreign body. So for the radial forearm, we offer a tube within a tube, and we do it as a staged technique. So creation of the pendulous portion of the urethra first, and then come back and do the fixed portion 3 months later. For the anterior lateral thigh, we again stage it. So it's 3 stages: creation of the shaft, then opening, laying in a skin graft, and then coming back and tubularizing the shaft.
Do you ever do a tube within a tube for an ALT, or have you tried it in the beginning and then abandoned it? Why are you using a graft material? Because I think that is something that people debate. I'm, for example, not using it. I know you and I have talked about that. But every surgeon has different experience. So I'm interested to hear how do you got to that?
So we did do a tube within a tube in the beginning, and still found that the girth of the shaft was, even in the thinnest patient, the tube in a tube was quite thick. And it didn't avoid the issues of the stricture rate or fistula rate at the neourethral junction. So for us, it didn't solve the problem that all of us, I think, face, which is the stricture, subsequent fistula formation at the junction. And I think that we have improved. There are certain things that we've learned along the way with the use of the graft. I think you have to completely open the ALT. So we're taking a 4-inch swath of tissue and laying it on the entire anterior lateral thigh. And we're also stenting it for the entire 3 months so that it really creates a nice trough. And we're doing physical therapy if we notice any kind of scar formation, injection of that area with Kenalog. And then also at the proximal portion in the base, which is where you're most likely to get a stricture, if when you go back to tube it, you really have to open that up and lay in more graft so that you're sure that you have a wide base, a wide urethral plate, essentially to tubularize. And so I think we've improved our outcomes in the use of a skin graft in those ways.
That's very interesting. So just for our listeners, so essentially when we talked about the staging in my introduction, right, you have the 4 bigger categories: tube within a tube in a single stage, doing the pars pendulum first, or you could do a metoidioplasty first, or you can use graft material. And then within the graft material, what Dr. Bluebond-Langner was talking about is the kind of post-lamination, or placing a skin graft as a second stage. And I'm very interested to hear all the things that you were talking about, technical modifications. Now, Marlon, before we go over to your preferred approach, I know that at Ghent, but maybe also Amsterdam, you have also used skin graft for urethral creation in anterolateral thigh flaps, but I believe you placed them beforehand. Maybe you can tell me a little bit more about that experience, and then afterwards, what your favorite approach is.
Yeah, so that's an experience that we have abandoned because of the high stricture rates and the high failure rates. What we used to do is we would lift up the ALT, place a skin graft on it, and then place it back. And then after 3 to 4 weeks, open it up and then do the rest of the reconstruction. So that's what we used to do. There was a time that we also cover a tube with skin graft, and that place that then under the skin without lifting up the whole ALT. So then you would have a cannula with a diameter of about 3 centimeters with skin graft around it, and then you would keep on constantly irrigating it, making sure that it doesn't stick, but that it would grow into the surrounding tissue. And then in a later stage, then tubularize it. The reason why we're not doing it anymore is because it didn't, as Rachel just said, we still have problems with strictures. We still had problems with the junction. So we stopped doing it because it was very intensive to clean it, to do an extra operation for the patient. And we had good results in one stage. So we decided not to do that anymore.
So Marlon, just out of curiosity, I mean, I think you point out like one of the differences in our technique versus yours is that we're waiting longer. So you can really see the skin graft evolve, like waiting 4 weeks, you're still healing their granulating areas, and those areas of granulation tissue obviously then go on to form strictures, narrowing. That's one difference. But how then, if you're doing it in a single stage, a tube in a tube, how are you addressing? We still find that at the junction, you can still get strictures and that it gets really thick. Even in the thinnest patient, the swelling we notice long-term in the ALT can be quite pronounced. It's almost like lymphedema that you have to use. We use wrapping, PT, all of that to get some of the edema out.
Mm-hmm. No. We also have a problem with that, because I mean to say we used to do the tube within a tube with ALT, and honestly, I stopped doing it. I mean, when I came there, I said, I'm not doing those anymore because, as you said, even in the thinnest of patients, it was not functional. I mean, you had a phallus that was but the girth was very big and they couldn't penetrate with that. And we had a few patients that we even did a resection and another resection, a little liposuction, name it. So we don't do that anymore. So if a patient wants to have ALT and a small donor site, we either use the skip, if they're thin enough, or just a strip of a free radial flap.
Are you offering that at the same time, or you're offering that
in one session? In one session.
And you don't find that the ALT swells and it becomes difficult to monitor the urethra, or that it chokes off, like, that one flap can choke off the blood supply of the other?
That's a learning curve. That happened in the beginning. And it has even happened with a few, once or twice, with a patient of which we first thought they were thin enough. Because it so happens that you think, when you pinch, you go like, oh, okay, this is a thin patient, and you make your design, and I usually take about 14 to 15 centimeters. I don't know how much that is in inches, sorry for that, but 14 to 15 centimeters. And it has been so that the subcutaneous fat was so fat that we couldn't close it immediately. So then I put an extra layer of skin, just a little, skin graft in between. And then when the swelling subsides, then you can always, just do a serial excision and just close it back. What I also do is make sure that I can see the inner lining of the urethra. So if the free radial flap or the skip flap. So make sure that it's marsupialized enough that you can always see it. Mm-hmm. And then I can monitor it, yes, by that.
This is an interesting discussion. I'm almost sad that I'm the moderator and can't partake more directly, but just to make sure that everyone understands. So in University of Ghent, like, your preferred method is still a radial forearm tube within a tube in a single stage, correct?
Yeah.
And then for patients who do not want to do a tube within a tube radial forearm and are desiring more an ALT, then you will offer either shaft only or maybe a composite flap with a skip or free radial. But you have also abandoned the tube within a tube ALT for most patients. Is that correct?
I don't do them at all for all patients.
So I still do tube within a tube ALT in actually quite a few patients, but I thin the flap a lot in the OR. So what are both of your thoughts around a thin patient and you just take the subscarpal fat and tell patients, well, maybe you're not going to have much sensation potentially because the nerves are at risk. Do you think that would be an option that could solve that, or you've tried that and also abandoned that?
You're saying that for an ALT, Jens?
Well, there's always the discussion of if you do an ALT, tube within a tube or as a shaft only, and it's way too big in the OR. Like as you both were saying, you try to tube it and it's just very, very big. And so some people do liposuction afterwards or direct skin excision, or you can thin it right there in the OR with a scissor, excise the subscarpal fat, which I do all the time personally and do it for tube within a tube. But again, people have different experiences. And so I'm curious to hear your thoughts on thinning of ALTs.
So we will thin a little bit, watching where the nerve, you can follow the trajectory of the nerve through the course of the tissue and make sure that you avoid it. I no longer do liposuction because I think that there's significant lymphedema in the anterior lateral thigh donor site to begin with. And even if you're not liposucking it afterwards, you have to manage that. I will offer direct excision along the ventral seam, but do have a discussion with the patient that if we have to reduce the girth, that you do jeopardize sensation. And there was one patient where we did do this and they lost sensation in the shaft and they were looking into having the phalloplasty completely redone because they had lost sensation in the shaft. And for them, that was devastating. So I think that has changed my practice. And I definitely now steer people with thicker thighs away from the thigh if they're concerned about girth. I think you have to be really upfront again about that trade-off and really understanding how thick is too thick. That'll vary from patient to patient, and making sure that you really talk about lack of sensation, loss of sensation, decreased sensation when using the thigh, which is perfectly acceptable to some people and a fine trade-off, but not for everyone.
Rachel, do you offer composite phalloplasties?
No. I have done a redo. So there was a patient who came to us from somewhere else that had a very, very thin radial form, had a stricture. So the urethra only perineal urethrostomy. So you need a complete reconstruction. So we turned the radial form into the urethra and then did an ALT. So it was the delayed reconstruction. So the ALT became the skin envelope for the shaft. The old radial form became the urethra.
I mean, it's interesting to hear, right? Because between just the three of us, we're at a stalemate. So I would never do a post-lamination skin graft, and I only in very rare cases will do composite ulnar forum ALT combination if someone doesn't have another option. And then we have Marlon, who would not do a tube within a tube or the post-lamination, and Rachel, who wouldn't do a composite or what I'm doing, which is kind of that's why we're having these conversations and this hot seat debate, which is important also for our research, right? So that we can compare and contrast, and maybe it's stuff that we do, something tiny little detail, as Rachel was saying, with the canalog, keeping the graft wide. But let's move on to the staging question. So I hear, Marlon, you're staging pretty much everything as a single stage, or do you, in a patient that hasn't had previous surgery?
It's always a single stage. We never do a two-stage operation. Just don't do it. Let's be honest, I've never seen it. Rachel, when we went to New York, we saw it, how you did it. And I'm still thinking about how did she do it? I'm still thinking about, okay, she did it, but so I still haven't done it. Sorry.
We have a video. I'll send it to you.
Thank you.
And so when you do your single stage, and so you're having two surgical teams, right? You have the urology team and the plastic surgery team all there on one day. Do you as a plastic surgeon see the follow-up in terms of the urologic issues, or essentially as soon as the flaps are healed, you don't really get involved anymore? Or
that has also changed a little bit in the last year. It used to be that we would see the patients, we do all the follow-up, and if there was a urological problem, we would send them to the urology, and still we would be, the go-to for all of the problems. Now this has been fought out with the urology. Any urological problem, they see them first, and then they ask us to help them with those problems if needed. So urological problems are for the urologist. Everything else is for us. But there are quite a few problems that are a cross-section for us and the urology. Because if there's too little skin, if there's a stricture that they need a new flap, and then it's for us, even though if the phallus looks okay and the pars pendulans is okay, if there's a problem at the junction, sometimes they need us to make another connection. So yeah, so then we are also involved.
Rachel, I know that you're staging. Let's talk about the radial forms you're doing. You're staging it the way that I do it, but as it was developed at St. Peter Andrology Institute in London, at least the baseline kind of philosophy behind it. Can you tell me a bit why you're picking the Big Ben method staging over, let's say, metoidioplasty first approach staging?
So I did do the metoidioplasty first. And what we find is that in the metoidioplasty first, if you're doing a form of metoidioplasty, you're bringing the urethra to the tip of the natal phallus. And when you then go back, you then have to deconstruct that. So you have to separate out the natal phallus or the clitoris from the urethra. And we found that when people come from other centers as well and have a metoidioplasty converted into a phalloplasty, often the caliber of the urethra is not a adult size. It's been calibrated to a 10 French catheter, which is not necessarily adequate for an adult bladder. That may be fine for a pediatric bladder, but not for an adult bladder. So in our hands, we find that the best patency rates come from if you don't touch the proximal portion of the urethra until you're really ready to tubularize and connect.
And so comparing to single stage, what do you think the benefit in your hands, in your medical setting, university setting, what's the benefit of staging it? Because, the advocates for single stage would argue that, well, yes, maybe 30% of patients or 20% of patients need an additional surgery, but in a staged fashion, 100% do. So, what is your argument to stage it?
I think you and I agree on this. I think that if you stage something, you and the patient maintain control of the timeline. And there are fewer emergencies, there are fewer emergent conversions to perineal urethrostomies, fewer people don't need emergent SP tubes. And a urologic emergency can be incredibly disruptive to a patient's life. They then have to walk around with a urinary catheter. It's additional unplanned time off from work. So we find that this is the way we have best control. We can address problems that occur up front, and it lays a more solid foundation.
So Marlon, like Rachel's saying that you can kind of separate the flap from the urologic complications. Do you agree? Do you have a different experience with single stage?
I just want to add one little thing, because I don't consider the metadoyo first as a staged operation, because we do have patients that have the metadoyo first. The reason being that because of their dysphoria, and we have a waiting time of about sometimes 3 years, 4 years, they decide to do the metadoyo first. So it doesn't really like we're staging it, but we're just treating their dysphoria by giving them at least the metadoyo to start with.
I think it's very important to be, especially, when we do research and talk about it, to make sure that it is a different surgery, right? Because you kind of, almost half of it is kind of done. So I would say it is kind of a staging. Do you feel you have different outcomes between your metoidioplasty first and the ones that you do as a true single stage, where you do the perineal urethral lengthening and the shaft urethra at the same time?
I must say, we think it's a trend, but we're not so sure if it really gives any better results. We think so, but we don't have any data to suggest. We do think there's a trend to that, but we're not so sure about it. So we still have to do the research our data and see if it really is true that it gives less problems. I mean, one thing it would give, of course, are the problems that we do see, like wound dehiscences with the scrotum, hematomas, and so forth. But that's not really the big problem for the phalloplasty. It's the urethral strictures. That's the one that gives the most problems. And I don't really think that we see, well, at least in our hands, we haven't really seen such a big difference between metadoyo first or the one-stage operation.
Now, Marlon, you work with a very experienced, urologist, Pete Höbeck. Is he still there, Professor Höbeck, or is he?
He's still there, but he's doing less work now.
But definitely a very experienced team. In your opinion, if you, let's say you were starting a new program somewhere in the United States at a hospital where the urologist may not have a lot of experience, and you're also you know how to raise a flap, you know how phalloplasty works, but you don't have decades of experience. Do you think a single stage is the right approach for that setting, or do you think the single stage requires a urologist that has, extensive experience within that domain?
That's a trick question, because that would mean that if I say yes, that would mean, of course, that it's more difficult to do a single stage than the two stage. So no, I would have to go with no. I think the thing of it is you have to have somebody that has experience, even if you do it in single or two stage. If you don't have the experience, you don't know how to handle the tissues in that area. If you don't know how it's going to react, it doesn't make a difference if you do it in one stage or two stages, you're going to get problems. So I would always suggest go by anyone, just anyone that has done it a few times, just have a look before you just start doing it, just reading an article and thinking that you can do it. That's what I would assume.
Of course, we all agree on that. It's just an interesting debate between various groups around what is the best way. And I don't think there is a best way of staging, but set and setting may matter in that debate.
The fact that there is a disagreement means there is not one way that is the right way, because everybody does it in a certain way and everybody believes that their way is the best.
Rachel, you were going to say something.
No, I agree with Marlon. I think the other thing is that our numbers, all of us have high volume for the procedure itself, but that's not high enough volume with long enough term follow-up to account for all of the different variations as well. So not everyone gets the same donor site. Not everyone elects for urethral lengthening. We do it differently. And so it makes it hard to create a data set that is reliable and allows for all the variations.
Rapid fire question to both of you. We have a lot more topics to talk about, but just one question to see whether or not we agree on that part. Urethral lengthening, meaning creation of perineal urethra without a vaginectomy, which is something patients ask for. Rachel, yes or no?
No. If we do urethral lengthening, we require a vaginectomy.
Marlon, what is your opinion on that?
Same goes. You want a urethra, you lose a vagina.
All right, I think that we found a common ground where we all agree.
How about hysterectomy at the time of phalloplasty?
Ooh, well, we don't do it. We do it beforehand. It just complicates the operation, makes it so much more difficult, more OR time, more chances of bleeding, etc., etc. So no, we don't. We used to, but we stopped doing it.
And then another question, when you do a vaginectomy, I mean, even if it's not you doing it, is it okay to fulgurize, meaning just maybe excise the anterior portion, but then, coagulate the posterior portion and close it? Or do you prefer a formal colpectomy, colpoclesis with excision of the vaginal lining mucosa? Marlon, which one do you favor, and are you against?
I prefer the complete or classic resection of the mucosa. I do know that our urologists, at times, if they do see one or two little epithelial cells, they will coagulate it. So I think usually it's a combination of the two, but mostly resection of all of the mucosa.
Do you think it's okay to fulgurize most of it, even if it's not your own setting?
I'm wondering, because I know that vaginal tightening is done by coagulation in a way. I mean, that's what they do, and that regenerates. So it would surprise me if you don't have some regeneration if you do it completely that way.
Just for the audience to give some context, the concern is that, once you close the perineum, that you could have a mucocele or, that the vaginal mucosa would recover and create problems down the road. So that's kind of that debate we're in. So Rachel, what's your opinion on fulgurization versus formal excision?
So we do formal excision, and to make sure that we've excised all of it, we stain the mucosa with methylene blue. We obviously do it robotically and use a lot of hydrodissection. We have seen cases where the vaginal mucosa has just been fulgurated, and patients have developed not only mucoceles, but they've fistulized and it creates a stagnant pool of urine, which then leads to chronic urinary tract infections as well. So we've seen vaginal remnants with fulguration alone.
Well, those were interesting discussions. Also, while I have the two of you, would love to present cases that are not quite cases of my own, but they've come quite in that constellation, and I'm interested to hear. So case number one, maybe we'll start with Marlon. We'll have a 36-year-old trans male identified patient with a BMI of 31, but he has had massive weight loss and presents with an overhanging panis, ptotic mons. He's otherwise healthy and really wants to urinate from his glands. All the support psychosocial factors, all that is in place. How do you navigate that request? What would you offer him?
To be honest, if I haven't seen the patient, of course, but if I read it this way, I would offer him, well, my choice would still be a free radial forearm flap. The reason being is that you're never too fat for a free radial forearm flap. I mean, for the donor site I'm talking about. For the patient itself is something completely different. I would consult him and tell them, of course, that because of the panniculus that he has, most probably would have to do a second operation in order to address that part. But I would do the phalloplasty first and then do corrections afterwards.
Have you ever had the feeling that if there's that much skin and monstosis that the urethral lengthening that you do either from superior inferior, either the flap urethra or the perineal urethra doesn't reach?
I've never had it because you don't look at the panniculus, you just look at where the mons pubis starts, so where the bony part is. So no.
A massive weight loss in the United States may have a bit more skin maybe than in Europe. So Rachel, you heard from Marlon, he would offer a radial forearm first, and then he would do a penniculectomy or a mons lift secondarily. What would you offer the patient?
I agree with that. If standing to void is his priority, I would offer a radial forearm, and I do agree with doing the mons resection. I would do the mons resection secondarily.
Oh, that's interesting. I always do it. I've had 5 or 6 patients that I've did a penniculectomy in preparation for phalloplasty. So yet another interesting thing to debate and see how the outcomes are. So thanks for that. Maybe I'll do it the other way if that case comes up again. Another case I have for you. So this one, Rachel, will start with you. A 48-year-old patient presents to you with a history of aortic valve replacement many years ago, psoriatic arthritis treated with IV immunomodulators every few months, and then also has at least a chart diagnosis of Ehlers-Danlos loss and autism. He has a strong support network, however, is well informed, he's read all and everything about it, and he really wants a full phalloplasty with urethra. How do you navigate a request like that? And are you going to offer him any form of surgery?
So I definitely think it's important to understand his goals and priorities and know what the patient is willing to sacrifice, if anything. I also think it's important to obviously consult with cardiology about what can be tolerated, consult with the rheumatologist about what kind of immunomodulation can be held or delayed during the healing process, and evaluate the Ehlers-Danlos and see how that would impact potentially healing. Sometimes it impacts, sometimes it doesn't. I, again, would stage it and begin with the creation of the penile shaft and see how that goes. And that leaves you some room, should things not go well with healing, to either reconsider your plan and reconsider additional surgery.
Marlon, you heard Rachel. So here, benefit comes in from staging it in terms of creating the flap first, right? Because you're not going to disrupt the genital region beyond a few minor modifications. So would you offer surgery at all in someone that's immunosuppressed and has a cardiac valve and all the things you've heard, or?
No, I mean, I would still offer them an operation, of course, and surgery, but I think I would offer them ALT, meaning because the operating time would be much shorter. Donors, I think they would have less problems, and I would not offer them, of course, a urethra. I would say that I would prefer not to give them the urethra. Try to explain to them why I would not give them the urethra, because of all of the problems that it could entail. Not that it will, but it could entail.
Yeah, I think I'm in your camp. I mean, one surgery that I really like doing, and I heard from both of you, is not something that you do a lot, is a lower abdominal-based shaft-only phalloplasty in the right patient, which is a relatively low-risk procedure. And I think all of your answers really speak to the fact, which is true for every patient, right, that we just have to individualize our decision-making capacity. Yeah. You know, for some people that are not in our field that may listen in today, they may think, well, I wouldn't, be offering surgeries, but everyone has to understand that these patients, they come to us and say, well, I had shoulder surgery last year and I would much rather live with shoulder pain for the rest of my life than not have these surgeries. And so we all try to find solutions together with the patient. And so just one last question, because I know it's getting late in Europe, and thank you again for taking time. Very quick question. Transplantation, meaning vascularized allotransplantation for the indication of a phalloplasty. for the indication of gender dysphoria. Is that something that you think will be doing in the future? Yes or no? And is that something we should be doing?
It sounds beautiful. I mean, to say if you hear it, you would go like this. Technically speaking, I would love to do it. Just pure technically as a surgeon, the whole operation is beautiful. I would love to do it. But knowing that people have to be on immunosuppressive for so long, we're talking about very young patients that are supposedly healthy, are going to go onto immunosuppressives for years and years to come, with everything that can go with all of the chances of having skin cancer, other problems. So I don't think we'll be doing that in the near future until we have something until we have the immunosuppressives that have less effects. So yeah, I don't think we'll be doing that in the near future.
I'm not totally convinced. I agree with Marlon. I don't think actually that allotransplantation solves the problems that we confront in phalloplasty. And so you still are going to have a urethral anastomosis. You're going to have the potential for stricture, fistula, especially that still remains the most distal portion and the most subject to ischemia, stricture, fistula. The second thing is that you are not going to be able to achieve an endogenous erection. You're going to still have to put testicular implants and an erectile device in. And as we all know, there are mechanical issues with placement of the erectile device. And you're also now putting an erectile device in a patient who is immunocompromised. So there's the baseline risk of infection, which is then increased with immunosuppression. So I think the two biggest Achilles heels that remain of the phalloplasty are your urethral strictures and fistulas, which I'm not totally convinced that we solve, as well as the erectile device, which I don't think we solve.
But that's why I would love to do, I mean, as I said, purely academically, I would love to do that operation just to see if we were able to resolve all that. If this would be something that would help. I mean, the strictures, because now you do have like with like. Because what's the biggest problem that we have with the strictures is that because you're doing skin to urethra. At least that's what I think is the biggest problem. So now you're putting urethra on urethra. So maybe that would give less strictures.
I would say it's still the circumferential anastomosis. You still have a circumferential anastomosis. I mean, you could try to break it up, but
maybe you're right.
Well, I think for today's discussion, I think that sums it up pretty well. We, there's so much more that we need to talk about, and I think because of COVID, we've all been missing going to conferences and actually having these conversations face to face. And so it was such a pleasure to talk to the two of you today, Dr. Rachel Bluebond-Langner from NYU and Dr. Marlon Buncamper from University of Ghent. And we'll see you at the next conference. And thanks for partaking.
Thanks so much.
Thank you. Seeing you. Good to see you all.
Good to see you.